Hello, everyone. Dr. Nick Verma here again with another edition of Things I Didn't Learn in Med School. Today, I want to talk about a few topics. First, I'm going to go over some RVUs, which stands for Relative Value Units. It's essentially a concept of how physicians are getting paid and reimbursed for their services. Another thing I want to talk about is the difference between payment in a surgical center versus an office procedure center versus a hospital center. And we'll go into some nuances of why there's different reimbursements on that as well. Hopefully you guys find this stuff useful. If you do, please share it to other people that might find it useful as well. And please subscribe to my channel. And also feel free to contact me. I'm doing this because it's stuff that I'm learning as I go and building my own practice. And I think it's important for me to share information, share my pain points, and really start discussing and having conversations about things that we didn't learn in med school. And I would be doing this anyway. I'm already doing it. And it's starting to become more of a learning experience for myself, just as much as a teaching experience for me. So anyways, I hope you guys are enjoying it, and please do share. So the first thing I want to talk about is, like I said, an RVU, a relative value unit. So, a lot of times these are talked about in hospital settings, or when we talk about physician reimbursement and how your reimbursement can come from a hospital or versus a surgical center or a large orthopedic practice. You might have your conversations based in RVUs. So what does all this stuff mean? So it's essentially based off of three different factors. We have a work RVU, and that pretty much talks about the physician time, how much skill it takes. That's why physicians with higher degrees of training, such as cardiothoracic surgeons, have a higher RVUs versus a general practitioner that might be doing a lower RVU type of procedure, maybe out of their office. It also involves how much time that procedure might take and how much skill it takes, and also the intensity of the service. So again, cardiothoracic surgery or neurosurgery is going to be way, way more complex than a basic trigger point injection that I might do in my office. So those RVU values, that work RVU value, is going to be weighted significantly differently. And that's usually the one that we're looking at the most. The next one is a practice RVU. So when they develop these RVUs, they also look into what are the direct costs, such as, for example, how much does it cost to have that, we'll use a trigger point injection, for example. How much does it cost to have the medications on board, the needles that you might need, the syringes, et cetera, et cetera. So these all kind of go into the play of a direct cost of the practice RVU. And then on the other side, there might be indirect costs. So that can be like staffing things. That could be scheduling the procedure. That could be getting prior authorization for the procedures and all those kind of things. So again, something that's very complex, such as a orthopedic surgery will have a higher practice RVU and require a significant more amount of RVU value for the practice RVU portion. And then the last one is the malpractice RVU. That should be self-explanatory. That's how much risk is involved in a case or a procedure that might be involved. So these are the three components. Again, it's a work RVU, practice RVU, and malpractice RVU. Now, typically, the only thing we're really looking at is a work RVU. That's really the one that is the most important for most physicians, the number we're looking at. But overall, all three of them go into the calculation. There's a great calculator on websites. You can just type in, I'm looking at it right now, that's why I'm looking at my computer screen, Rvu Calculator. And this kind of helps walk you through this similar process. So just for an example, you can have these RVUs as well for something that's just as simple as an office visit. I'm just looking right here, something that's based off of the AAFP coding and payment opportunities webpage. It has a 99214, which is an established patient office visit of moderate to high complexity at 1.5 RVUs. So that's just not that. Oh, sorry, the work RVU is 1.5. The total facility RVUs is 2.21. It doesn't have the malpractice RVUs; those are usually filtered in somewhere else. Regardless, so what they do is they combine all these RVU values: the work, the practice, and malpractice. Work RVU, practice RVU, and malpractice RVU, and they multiply it by a conversion rate. Now, the conversion rate is dependent on the area that you live in. And these conversion rates, I don't actually have the examples off the top of my head, but they do seem to vary from region to region. So you might hear someone in New York gets a significant higher amount of RVU based off their work versus someone that's living in Ohio, for example. And this is based on regionality and kind of goes in correlation with what the malpractice RVUs have to do. Now, this is how it was explained to me through a physician, and I might be making this a little bit more complex than it needs to be, or some might be saying I'm making it easier than it needs to be. But this is just the generalities. I think the overarching framework that I think is important for anyone that's going into private practice or that may be interested in these things. This should be the overarching point that everyone should get across and understand. So I hope that made sense. I'm just going to pop on to the AAPC website real fast. It says here work RVUs are most frequently used in the component of resource-based relative value scales. So that's something to keep in mind. Different practice and malpractice RVUs, so kind of all this stuff. And this is, again, the RVUs is something that practices and hospitals and or multidisciplinary groups, they all use these RVU values as a framework of what they can pay people and what they can afford to pay people. And they kind of balance this over the course of the year, and they know what someone should be expecting to make over RVUs, et cetera, et cetera. This kind of gets a little tricky when you work with people that are strictly salary based and they're not working on an RVU practice model, or where they're using a different metric of a value-based model where if this practitioner brings in X amount of money, then they'll start looking at different aspects of reimbursement for that physician. So these are just some things to think about. We can definitely talk about that in a future video, but I want to kind of explain what RVUs are. I think it's important. And actually, this does bring out a good point about physician negotiation and contracting when they're looking for practices to join. There are data that's been produced over the years, and the data points, they essentially, what they do is they use this MGMA. I'm not sure exactly what it stands for. It's a benchmark data point that actually compiles all the physicians in that specialty and kind of puts them on a spectrum of highest paid to lowest paid, what their work RVUs were for that year. And they kind of do some other data points. But what it does is it kind of shows you where you are on an average RVU, or what a physician should get for that practice for that RVU in a course of a year. So I want to give an example. This is completely hypothetical from the MGMA data, and this is around 2019. A physician could be, let's just use the 2019 national average data from the MGMA. Again, it's a benchmark data point. For a non-anesthesia pain physician, the average was 494,229. The median, the middle, was 447,905. So that if you broke that down to compensation per RVU, that was about $81.94 for the mean and about $73.01 for the median. So that's essentially what their base mark of RVU was valued to that individual in that practice. Again, that was non-anesthesia pain. So here's a hypothetical way to look at contracts when you are looking at them. You look at the total compensation, it might say $400,000 for the year. The total work RVU productivity would be 7,000 RVUs. So if you divide 400,000 by 7,000, you get dollar per work RVU compensation. Comes around to about $63 per work RVU. So if we use that example for 2019, that 494,229 divided by X amount of work RVUs, which is around 7,000 work RVUs. I feel like that's a good benchmark. That's where they got the equation of $81.94. Someone can check my math. This was something I wrote down last year, actually in my fellowship. So that was almost 2+ years ago now, when I was kind of looking for physician compensation and how contracts are made. So hopefully some of that stuff made sense. We will definitely have a longer format conversation about the MGMA. There are other benchmarks out there. There's an AMGA, there's a Sullivan Cortex, a Becker's, a Merritt Hawkins, a Doximity, and then there's also anecdotal evidence or anecdotal conversations out there. Just a general word of advice, trying to find a base compensation about 50 percentile and add what your work RVU to the 50th percentile. You don't want to be working very, very high RVUs and getting a less than a base compensation. And also at the beginning, you don't want to be getting paid significantly less for working, you want to be working significantly more for less money. But also, it should make sense that you shouldn't be overproducing yourself and having a work RVU that's way lower than the 50th percent. It should really correlate close. And sometimes practices will start out lower and let you grow up to the appropriate one. Again, we'll talk more about this in detail in another video. And hopefully I'll get some experts on that can explain some of these things a little bit more. So the next thing I do want to talk about, though, is we always have this conversation. It's more of a conversation, not an argument, about what's better. Should we do practice-based, office-based procedures? Should we do these in a surgical center? Should we do these in a hospital? And it's a great conversation to have because I think it's really important to know what the differences are. First and foremost, there are certain procedures that are only approved for a hospital setting. So we should just put that out there. And this tends to be especially newer procedures that come out. Sometimes they are only offered in hospitals. And as they're working on getting clearances from the FDA and get clinical trials out there before it can get moved to a surgery center. So just keep that in mind. Some procedures 100% need to be done in a hospital. Sometimes that's why we do credential with the hospital, so we can do these procedures there. Now, the next thing would be there are certain procedures that have to be done in a surgery center or a hospital system. So that's something else to keep in mind. And I'm going to pause there and go to other things. And there's other things that can be done in any setting. Office, surgery center, or a hospital. Okay, so we'll start there. So I want to start with an office setting. This is my setting. I have my own procedure suite in my own office. And let's just talk about what it costs. So I have to have office space rented out or on my own office space. I have to get a C-arm. This is a fluoroscopy-based procedures. There's different types of procedures out there, but as a pain specialist, I'm going to talk about the fluoroscopy-based procedures. Again, so I have to pay for the C-arm, and this can be anywhere from $10,000 to one that's probably cheap and you don't want to trust, all the way up to $120,000, $130,000, $140,000, $150,000 C-arm machine. Now, for the kind of middle of the mark, that's what most people are using, spending around $60,000, $70,000, $80,000 on a pretty decent machine that has high reliability and high comfort rate for physicians to use. I'm not going to say how much I spent on mine or how much I leased mine out for, but so you either buy this outright or you lease it. So these are office-based expenses that have to go into your P&L, profit and loss segment of your monthly finances. So that's something to keep in mind. Now, you also have to you have to contract with companies to get needles, medication, you have to get lead, you have to get the C-arm certified by the state, which costs money. You have to make sure that it's up to date with the radiation regulations, more money. You have to make sure you have all the radiation regulations up to date. So all these are, slowly building up to adding in a lot of money and time. And, it takes time away from you being a physician to actually put money and time and effort into getting all these things done. You also have to get a table, a certified fluoroscopy table and those are also pretty expensive. Can be anywhere from a few $1,000s to $20,000-$30,000, especially the ones that move in multiple directions, which we typically do need in our most of our procedures. So all these things cost overhead, and then you have to hire a staff member that can operate a C-arm. In the state of Ohio, you have to be a certified radiological tech to operate a C-arm. There are other places that you don't need that, but also a physician can get their radiology license to operate a C-arm. In this case, essentially someone else can move the imager, but we are the ones that are responsible for taking the image and saving the image, and we're the only one that can do that. So that's something else to keep in mind. And then if these things break down, it comes out of your pocket to fix these things, and there's no overhead that can kind of help with that. You have to justify the fixing cost of that. So if we go to a surgery center, just think about all those things I talked about, the medications, the needles, this, that, and the other. So in these surgery center models, there are usually a group of physicians that are bought in. So they've spent money and they've contracted to be part owners in the surgery center. And then you have either private equity groups, you have hospital systems, or you have outside investors that also invest into it. So they we'll just say throw out a number of $1 million, and they put all this money together to build a surgery center, buy those C-arms, hire staff such as nurses and techs, the radiological techs. They get all the equipment, they build everything up, et cetera, et cetera, et cetera. So now what ends up happening is at the end of the day, all the procedures are done for the day. They will compile the money, they'll pay all the staff, they'll pay all their overhead, and whatever's left, those physicians that bought in and the private equity group or the private investors or the hospital will get some reimbursement rates back. And we'll talk about why that's all important in a little bit. And in the hospital system, again, so if something breaks down or something gets a problem, the private equity group or the money that's compiled into that big pot kind of goes out and is distributed to help pay for the cost of issues that come up. Usually you have different level of managers who kind of run different portions of the surgery center to make sure things operate smoothly. And then the hospital system, just imagine that same surgery center concept, but in this setting, the hospital is the one that owns the surgery room, the C-arm, and all that stuff. And then the employees are the ones that are doing the work at the hospital, such as a physician doing the procedure, but also the staff is all employed by the hospital. Okay, so what does all this mean? So in a office setting, for an epidural, and I'm giving arbitrary numbers that may or may not be true for me or different people, but so in an office setting that I would do a procedure, say just a basic interlaminar epidural steroid injection, I would get, say, $300 reimbursement from the insurance company. And that's what my physician fee would be, and that's all said and done. But out of that $300, I have to pay my C-arm tech, I have to pay for the medications, I have to pay for the needles, all that front-end work I did on the approval of the C-arm, all that stuff. So it's all coming out of pocket. So that $300 may turn into maybe a $20 profit at the end of the day, and that goes right back into the business bank account. So in a surgery center, if I do that same procedure, my physician fee actually gets cut down a little bit. So that same procedure, that basic epidural steroid injection, maybe, I don't know, we'll say $200 for the sake of argument. And that's what my physician fee is, and that's what, I would get paid out of the insurance company. Now, there's also what's considered a facility fee. And now this facility fee is much higher, and that reimbursement is also much higher. Because the insurance companies know that the surgery centers have spent a lot of money to build up these centers that are of state of the art, and they're making sure that it's getting better patient outcomes, and they're tracking data and all these other things. So they're giving these facilities a higher fee to reimburse them. So now that I get $200 for my procedure portion, and the facility gets, we'll say, another $800 for their facility. Now the facility will, again, use all their money to pay for their overhead, and all that money that's left over gets distributed into any of the partners that are in that setting. So, for example, if I was partnered with a surgery center, say the Nikhil Verma Surgery Center, and I was one of the owners with 4 other people, so 5 total owners, and there's 5 other people that are private equity owners, the shares. So there's $1,000 that was total into that payment. That would get divvied up into into each shares of the owners that are into it. So that $1,000 gets split 10 ways, and now everyone gets $100. So I'm losing money on the front end because you would say it's more lucrative doing in your office. Why are you doing it in a surgery center? Well, that's just for my procedure. Now think, if you have 4 other surgeons there that are doing procedures at a high rate or an accessible rate, now whatever procedures that they're doing, they're also contributing to that overall fund. So instead of $1,000, it becomes $5,000. And so instead of $100, now I get $500. So this is why people will partner with ASC. Now, to buy into an ASC, it takes a lot of good faith. You have to show that you're competent. You have to show that you can bring enough volume to the ASC. You have to meet with the committees. You have to get signed off. So it's not just easy as I'm going to walk into a surgery center and buy in. And it does take a lot of effort, and you have to have good work. You have to be able to work well with others. You have to be cordial in your environment. Your patients have to give you good remarks and good liking. You also can't be bringing types of patients that are going to cause issues, such as if the surgeon does a lot of highly aggressive cases that can cause a lot of infections, that looks poorly on the surgery center. And so it's there's a lot that goes into it, and maybe this is why the facility fees are so high. Now that same concept of the facility fee and physician fee, that also translate to a hospital. Now the hospital rates, again, are even higher than the facility fees at the surgery centers. So now, in that case, though, the hospital is the one taking all the money after they divvy up all their reimbursements. Now their reimbursements, overhead, not reimbursement, their overhead is much higher at a hospital. You have a lot of things to keep, a lot of lights to keep on, a lot of people employed by the hospital. You have a lot of things going on. So this is why that reimbursement will be higher in that setting. So I hope this cleared some things up. It seems like nowadays a lot more people are doing procedures in the outpatient setting, or either in the office or at a surgery center. And I think that trend will continue to go in the next few years. It may change until we see some change in healthcare, because patients are getting faster results. They're getting in sooner. They don't have to wait around the surgery in the hospital. Most of these outpatient procedures can be in and out with highly efficient surgery centers. And you just get a little bit more hands-on care, and you're not feeling like you're part of a bigger system. And maybe this is my opinion, and maybe I'm completely wrong about it, but that's just the way I see it. There are certain procedures that the spinal cord simulator trial reimburses really well in your office, so a lot of physicians like to do those in their office. A kyphoplasty procedure is another one that tends to reimburse very well, so people tend to like to do it in the office. And now these have been deemed safe enough to be done in the office. But with that being said, you should have someone that's highly skilled, highly trained, knows how to handle a crash cart, knows how to understand basic airway management. All these things are important if you're doing these in an office setting. Not that it happens often, but if it does happen and something goes wrong, you do want to be trained well enough to know what to do. In a surgery center, it's the same thing, but you actually have the extra staff available, more people that are trained, more hands-on. If a code were to happen, you can run it with a full effective team with a crash cart instead of 1 or 2 people trying to manage it in an office setting. And in a hospital setting, obviously, you're in a hospital, so if something were to go wrong, there's an entire hospital filled with physicians, nurse practitioners, PAs, nurses, techs, et cetera, that are able to help. So, all right, that's it for tonight. I think I have a lot more topics I want to come to in the next few months. I want to talk about just the basic of financing and finances for medical students and residents and fellows. Really what I'm going to do is just run through a list of 10, 15, 20 things that resonate with me, that I use as resources. I'm going to also talk about contracts and how to look at contracts. We talked a little about it today, but we'll talk about it more in the future. And then we'll also talk about job settings out there, what environments are out there for people, and hopefully in the next few months also I'm going to start interviewing people. They can be doctors, they can be doctors, they can be nurse practitioners, physician assistants, chiropractors, physical therapists. I'm just going to start having these conversations. What didn't I learn in med school that you can teach me, and what more am I missing that I need to know, that I should know about navigating this healthcare community. So anyways, hope it was useful. Please give it a like and share it with anyone that may find this beneficial for them, and look forward to talking to you next time.